Hello, my name is Dr. Gilbert Simoni, and I'm here to talk to you about gastroesophageal reflux disease and its newest treatments in the 21st century. One of the first things I wanted to do was to thank Los Robles Hospital Medical Center for giving me the opportunity to do this. And before I go on and give you the lecture, I wanted to just give you a bit of a overview of my practice. I've been in practice for almost a couple of decades. There are four things in my practice that are very important to me. Number one is prevention. My job is really to prevent cancers. I'm involved with doing preventative colonoscopies, endoscopies. We look for some other things that could actually cause cancer. So I'm very involved with prevention. The second thing about my practice is that I always try to utilize the most cutting-edge technology in treatment and also for diagnosis of patients. And also, I try to use the latest technology to offer those treatments to patients. Last but not least, I'm fortunate to have really high patient satisfaction thanks to my network of hospital physicians and my office staff. So without further ado, I'm going to talk about gastroesophageal reflux disease. One of the first things that I always lecture about is the fact that physicians really and scientists, we like to use acronyms. So GERD, or gastroesophageal reflux disease, is what we're going to be talking about today. So what is GERD? GERD is essentially upsplashing or movement of the contents of the stomach coming up into the esophagus and causing issues. So why is this a problem? Because it can actually lead to more serious issues. What I have here is a video of what gastroesophageal reflux disease, or GERD, actually looks like. So as you can see, when someone has a normal valve, and you can see the area where there's a tight valve between the esophagus and stomach. In a normal situation, when you eat food, the food goes into through your esophagus into the stomach. The valve opens up, then it closes, allows the stomach to churn the food, and then force it into the small intestine. Conversely, when you see a patient who has a loose valve, the food goes into the stomach, and then it unfortunately splashes back up depending on any pressure that's being put on the stomach or the amount of food that's eaten. So then it's a mechanical forcing of the contents of the stomach coming into the esophagus that actually causes gastroesophageal reflux disease, or GERD. All right, so one may want to ask, so what's wrong with a little bit of reflux? Unfortunately, the diagnosis of gastroesophageal reflux disease can oftentimes be difficult to make because not everybody has what we call typical symptoms. So we categorize symptoms of gastroesophageal reflux disease into two different categories. One is symptomatic or typical gastroesophageal reflux disease symptoms, and we also have atypical gastroesophageal reflux disease symptoms. Typical symptoms are the ones that are very well known. Generally, people have heartburn, regurgitation, having acidic taste in the mouth. You know, those are things that are everyone really knows about. We call those typical symptoms. The difficulty is generally when someone has atypical symptoms of gastroesophageal reflux disease. The reason for that is that oftentimes it's not really clear whether they have GERD. As you can see in the list, there are patients that suffer from chronic sinusitis, chronic cough, hoarseness of the voice, even dental erosions. These are things that can be actually related to gastroesophageal reflux disease, but oftentimes patients may have to go through several different evaluations or different physicians until it's diagnosed appropriately. So what are the dangers of gastroesophageal reflux disease? What happens with reflux, the contents of the stomach come up into the esophagus and cause irritation or inflammation of the esophagus. Ongoing inflammation of the esophagus can actually lead to damage to the esophagus, such as esophagitis, and eventually can cause Barrett's esophagus. Barrett's esophagus is a precancerous change that happens in the esophagus, and if it's not treated, can actually lead to esophageal cancer. It is really important to recognize that esophageal cancer is a deadly disease. Unfortunately, once it's diagnosed, a lot of times it's diagnosed at the late stage, and patients may not survive or have a very low 5-year survival rate. The other important fact for esophageal cancer is that over the past several decades, it actually has increased about 700% in its incidence. And part of the problem that I see is the fact that, unfortunately, we don't have any screening tests for esophageal cancer the way we do for most other cancers. There's a slide that basically shows a graph about how other cancers, such as breast cancer, colon cancer, have actually declined after having had screening measures, but unfortunately we don't have that for esophageal cancer. So each individual who has symptoms, they really should be screened for gastroesophageal reflux and esophageal cancer. Some of the facts that are very important in GERD are the fact that there are more patients than we think that have GERD. It's estimated that even if you have once a week GERD symptoms, it actually does increase the chance of esophageal cancer. So it is really important for us to try to minimize that progression to esophageal cancer by early detection and treatment. Other things that I would have to mention about gastroesophageal reflux disease is how much burden it puts on the healthcare and how expensive it is. It's estimated that about 80 to or over 80 million Americans have gastroesophageal reflux disease at least once a month. About half of those patients have about weekly gastroesophageal reflux disease. The other half have it either monthly or daily. Other important fact that you can see here is that most patients who have GERD are just treated with medications, and that actually is a very high cost of healthcare with these medications. And the problem is that these medications don't actually fix the underlying problem. The other issue is that a lot of the patients who actually develop GERD do not really get the proper evaluation and treatment by appropriate physicians. Only about 10% of the people that have reflux actually get evaluated properly. So we just talked about a little bit about medications for treatment of gastroesophageal reflux disease. The other issue with these medications, aside from being expensive and costing a lot in or increasing our healthcare costs, is the fact that they also can have problems or side effects that can happen over a long period of time of using them. There's a slide I have that actually shows several different scientific evidence behind these side effects or long-term problems with the medications for reflux, which we, by the way, call them PPI or proton pump inhibitors. The most notorious of these issues is actually osteoporosis, which has to do with decreased bone density. As patients take these medications over a long period of time, they actually are at a higher risk of getting hip fractures or spine fractures and wrist fractures. There are some other issues also that can happen, such as kidney problems, cardiac issues, even at some studies show that it actually can increase stroke incidences. One of the most recent scientific studies that brought to our attention the fact that proton pump inhibitors are dangerous to take is the pandemic. Just this past summer, there was an article that came out indicating that patients that actually take double dose of the PPIs are at higher risk of developing COVID-19. So that's another issue that actually has come up recently. What do I recommend for patients in order to get screened and taken care of who have GERD or suspect they have GERD? I have a list of symptoms that would really recommend, in those situations, I would recommend that you have a screening test, such as endoscopy. Patients who have persistent cough, sinusitis, dental erosions, even asthma, throat clearing, as well as having hoarseness of the voice. These are issues that could actually be related to gastroesophageal reflux disease. The best thing to do is to actually have a gastroenterologist who is an expert in GERD to evaluate you and offer treatments if it's necessary. How do we do the screening test? It's a very simple test. It's called an endoscopy or upper endoscopy. As I said, we use acronyms a lot, so it's also called EGD or esophagogastroduodenoscopy. It's simply about a 5-minute procedure. When you're asleep or sedated, we pass a flexible small tube with a camera at the tip of it through the mouth that goes through the esophagus into the stomach and the first part of small bowel. We look at a lot of different things during that 5 minutes. We look at the stomach, we make sure there are no ulcerations, we check for celiac disease, we check for hiatal hernia or loose valve. We also check for Barrett's esophagus. And as I said, it literally takes about 5 minutes. And we get a lot of information from that 5 minutes of evaluation. So what do I see when I do an endoscopy? There's a image here that actually shows the lower esophageal sphincter anatomy. You can see how things look from endoscopy within the esophagus. You can actually see a nice tight valve at the bottom of the esophagus. And then when we get into the stomach, we like to do a turnaround, or what we call retroflex view. And we actually look at the top of the stomach where the esophagus and stomach meet, and they create the valve. So as you can see, the valve is really tight around the scope. It's that black tube that you see. And that kind of gives me an idea as to how tight the valve is, or if it's loose and requires treatment. So this all is done during the endoscopy. Here are some of the normal versus abnormal lower esophageal sphincter, or images that you can actually see during the endoscopy. On the left top, you can see, again, a normal valve. The bottom is a schematic of what a normal valve anatomy is supposed to look like. On the right, you can see a large hiatal hernia. There's a large depression or gap around the scope. That's a hiatal hernia, and you can actually see the anatomy of it below that, where you can actually see the part of the stomach herniating up into the chest. And when we go into the stomach, we can actually look back and evaluate that. And we can also find out how large the hiatal hernia is and actually measure that. Let's say we have actually did evaluation and someone does have GERD and they do have these endoscopic findings such as a hiatal hernia. What do we do next? Well, traditionally, patients have been on drugs to reduce the symptoms. Unfortunately, drugs are just Band-Aids. They only reduce the symptoms by reducing acid of the stomach. And one of the major misconceptions is that gastroesophageal reflux disease is not necessarily due to overproduction of acid or having too much acid in the stomach. It really has to do with the mechanical issue of the valve between your esophagus and your stomach. So just giving pills to the patients doesn't really take care of the underlying issue, which again is because of the loose valve. Over the few decades, there's been many different surgical interventions. A lot of these surgical interventions have been invasive and actually having to have the patients in the hospital for some period of time. In 2008, FDA approved a relatively new intervention. It's called the TIF procedure, or transoral incisionless fundoplication. This is a non-invasive procedure that can be done as an outpatient, and it requires a minimum to no hospital admission. It also has been shown to not only fix the valve, but can also reduce the hiatal hernia and get patients off of the medications. So what is TIF? Again, it stands for transoral, which means through the mouth, incisionless, which means without cutting anything, fundoplication, which is essentially fixing the fundus, or the area where the valve of the esophagus is supposed to be, or lower esophageal sphincter. The device that we use for the TIF, it's called an esophagus device. An endoscope actually fits through that, and we pass that in through the esophagus into the stomach. We turn around, and the device actually grabs the loose tissue around where the valve is supposed to be, and we create a pleat. Basically, we pull or invaginate both the esophagus and stomach together and put some sutures or small, tiny plastic or suture material, H fasteners that they're called, and we create the valve by going around in a 270 to 300 degree fashion, creating what your normal lower esophageal sphincter is supposed to look like. It's essentially almost like creating a purse string, if you will. So this is done under general anesthesia. It essentially takes about 20 minutes or so. Oftentimes patients go home within a few hours after this procedure. It's non-invasive, and it's relatively rapid as opposed to the previous predecessors or more invasive options. TIF actually recreates the valve, and by bringing the esophagus and the gastric lining together, we actually create something called a serosal fusion, which are scar tissue that forms between the esophagus and stomach, and that actually lasts a lot longer. So I oftentimes get asked by patients, do the sutures stay or do they fall apart? The sutures are just there to temporarily hold things together until your own body produces the scarring or being able to actually adhere things together, and that will last a lot longer. I have some evidence of example of patients that we've had before. As you can see in this particular image, patient had a relatively large hiatal hernia. This particular patient actually had a long-term gastroesophageal reflux disease and did develop Barrett's esophagus. So we ended up doing a TIF procedure. Normal, you can actually look at the difference between how his previous to TIF hiatal hernia was and how his valve looked after a few months. And interestingly, his Barrett's esophagus also went away. We did this procedure several years ago, and his follow-up endoscopies have all been essentially negative for Barrett's. So there are some, just like any other surgical procedure, there are some indications and contraindications. The most important indications for TIF procedure are patients that actually have chronic GERD or gastroesophageal reflux disease, and they require medication if they're above 18 years of age, and they have a BMI of less than 35. The contraindications, conversely, are the ones that patients who have a high BMI, if they're younger than 18, if they have any dysphagia or problems with swallowing, and certain conditions such as autoimmune diseases like Sjogren's disease and achalasia are contraindications to having the TIF procedure. As far as information about safety and efficacy of TIF procedure, there's been more than 80 some odd scientific papers and studies that have been done on TIF. They all have shown significant safety that essentially TIF is extremely safe and effective. Personally, I've been doing TIF for more than 10 years. More than 90% of my patients are off proton pump inhibitors or medications, and it has less side effects than or adverse effects than doing regular colonoscopies, if you will. We have much less complications, if you will. There are some minor, about somewhere between 2 to 4% chance of failure, and that also has to do with certain factors such as gaining weight, which could definitely put pressure. But overall, TIF procedure has been extremely well received by patients. Most of my patients have done extremely well, and we have been doing the TIF procedure at Los Robles Hospital since 2008. We're one of the first hospitals actually that started doing that in Southern California. If you have any questions or you have any of the symptoms that we discussed and you'd like to learn more about TIF or be screened for Barrett's esophagus and see if you're a candidate, please come and see me. Thank you.